I decided to do my presentation on a statewide obstetric hemorrhage quality improvement initiative. Some facts that I found are that the rate of maternal deaths in the United States have almost doubled from 1996 to 2006, according to the California Department of Public Health. Maternal hemorrhage was the third leading cause of death in California during 2002 to 2003, and 70% of those deaths were reviewed and deemed potentially preventable. So the project description is that the CMQCC used multiple level strategy to spread the guideline. The CMQCC is a California Maternity Quality Care Collaborative, which is a statewide multi-stakeholder quality improvement initiative. The project design was to open access toolkits, to use minimal support mentoring model, and to start a county partnership model that would include 30 hospitals and a learning collaborative. The mobilization of the hemorrhage task force included interviews and small group meetings with physicians, nurses, and midwives. It also identified community concerns to raise awareness and lay foundations for mobilizing volunteers. Maternal quality improvement panel expert physicians and nurses who would oversee the California Maternity Quality Collaborative initiatives. Some data that they collected was that the first idea was to ensure that more women have access to high technology approaches, including interventional radiology. They also wanted to realize that there needed to be universal, low-tech solutions that can be implemented in all care settings. Some challenges that they had were staffing and financial constraints, as well as analysis such as detailed diagramming of care and process. Also, OB hemorrhages varies among clinicians. So what was done? A compositive case study, which included a mortality review panel, and they developed a study of concern elements of the maternal deaths. Also, low-risk pregnancies and births can quickly escalate to emergent situations and deaths when the amount of blood loss goes unnoticed after birth. They also did a survey of California's hospitals where they would assess the baseline status of the hemorrhage-related structure and process the indications in the different hospitals. So it was due to the clinicians' perceptions of barriers due to effective hemorrhage care. They received 130 responses out of the 206 that they sent to different hospitals. So what did the survey say? They concluded that there was 3 key barriers: inadequate assessment, lack of accurate and consistent estimation of blood loss, and problems with communications between the team and their teamwork. The overall data of both of these assessments said that there was inconsistent definitions of hemorrhage. Also, there was a lack of hemorrhage policies and procedures in the hospitals, and few physicians participating in the hemorrhage drills that were taking place. Also, there was a lack of familiarity with treatment, and such as intrauterine balloons and B-Lynch suturing. Also, blood loss is too subjective. A lot of times people just say bleeding a lot, but what does that really mean? So the plan they put in place was 4 things. They were going to improve the readiness, they were going to improve the recognition of the hemorrhage, they were going to improve the response of the hemorrhages by performing regular interprofessional hemorrhage drills, as well as improve the reporting of the OB hemorrhage by standardizing definitions and improving the consistency of coding and reporting in the hospitals. So they created an OB hemorrhage care guideline where they would have a bedside checklist that would help guide the team if this were to arise. Also, they had 2 cognitive aids, a table and a flow chart that would be present in the most critical points of the obstetric unit. Also, care guidelines would be used to walk the user through the action steps to take at the point of care. So there were 3 categories of action. They wanted to mobilize so that the team members would all engage. They wanted to act so there would be specific actions and medications to take place to be able to treat if hemorrhage were to happen, and also think to encourage the team members to maintain situation awareness and future planning. So there was 4 models of implementation. The first one being minimal implementation support, where the clinicians would use the OB hemorrhage toolkit to implement change among themselves. The toolkit guide was policies and procedures, discussions of tactics, and a measurement grid of tracking progress. They would also send out host and e-news announcements to report the information to all the hospitals that were involved. So there was also the moderate implementation support, where they would have a web-based data that would be able to collect and benchmark the hospital-level data and generate real-time reports of the hemorrhages. The third one is the support for county public health community partnership, and they will provide technical support to the maternal child care county public health leaders, as well as providing day-to-day oversight for OB hemorrhage projects. The fourth one is the intensive implementation support, where hospital-based groups would register and pay to work together over an 18-month period following the Institute of Healthcare Improvement, as well as project leaders who would submit the data through a web-based tool, and project leaders who would attend 3 meetings and monthly phone calls to talk about the challenges and the successes of these new toolkits being implemented. So what we found, nurses are the key. Nurses are leading the collaborative's efforts to move away from estimated blood loss to now use quantification of blood loss. But some of the barriers that they experienced were, how do we weigh these blood-soaked materials? How do we measure the fluids in the containers accurately? How do we document ongoing records? And also, how do we standardize these supplies? So what they did was they would have laminated cards listing dry weights that would be attached to the scales. So the evaluation of this quality initiative, they recommended process measures. They also noted the number of clinicians who participated in the drills, the percentages of the charge with which the quantitative blood loss is reported, the number and type of maternal blood transfusions, and they would also encourage hospitals to submit data through a debriefing that included stage 2 hemorrhages or greater. So the clinical implications of this study were to improve the readiness. The hemorrhage toolkit would list and also include the supplies and the templates needed if there needed to be implementation. They would improve the recognition. The toolkit would include a statement on quantitative blood loss and a sample set for SkillStation to improve recognition. They would improve the response of the leaders by having interprofessional drills based on the written care lines, and they would debrief after each hemorrhage to go over what went well and what didn't. So they found that only by working together can we make these changes to ensure high-quality maternal care to mothers and their families. What sparked my interest to do this project was how it relates to the lecture and what we've been learning. Also, the death rates are way too high, and we need to be able to do something about it in the future. I also love how this quality improvement is focused on the nurses and what they can do to help. And overall, it's just a collaborative work that can be used in hospitals to make sure that everything's running smoothly and we all can work together. Thank you.